Good afternoon, everyone, and you are very welcome to the first of our webinars in 2025. And I'm delighted to say it's going to be a super webinar today, and I'm delighted to welcome Dr. Hardeep Singh, who we will get to hear from in a few moments. Do follow us on social media. We're on YouTube, and you can watch back all of our previous webinars on our YouTube channel, and we're also on LinkedIn. And again, we'd encourage you to follow us there and learn about future webinars. So just a couple of quick notices to make people aware of some resources. Obviously, the Patient Safety Act, which has been operational now since last year, there are some really useful resources there if people want to make themselves familiar with it, or if they've got particular questions. So again, the QR codes are there. They are available on the National Quality and Patient Safety Directorate website. So please familiarize yourself with those. We have a new New Year Quality Improvement Toolkit, which is really a consolidation of lots of the resources that we have. And Chris is going to put the link to that into the chat. And again, if you want to check that out later, it brings lots of resources into one place, and I'd encourage people to become familiar with that and share it, please, with colleagues. And then this is exciting. IQuESt is our new network for quality and patient safety research, and they are hosting a winter webinar series. And again, the QR code is there with lots of information and the links. And the next of those sessions is going to happen on Thursday, the 16th of January, so on the Thursday this week. And that is with the National Office for Clinical Audit, NOCA, and the National Centre for Clinical Audit within the HSE. And so that'll be well worth checking in. And you can see there's future sessions, an introduction to human factors at the end of the month, and then a session with the National Simulation Office in February. So do again put those on the radar and share them with your colleagues. And so today, this is episode 30, and again, it's a pleasure to be here on the first of our webinars this year. We're going to explore the area of diagnostic excellence. We're going to maybe learn a little bit about why we're talking about diagnostic excellence rather than diagnostic error. Going to hear about how we as clinicians, and again, I think diagnosis perhaps used to be very much in the remit of doctors, but it's now in the remit of many clinicians and many people within the health service. And we're going to hear a little bit from Dr. Singh about his research, and he really is a world expert in this area. So it's a pleasure to welcome Dr. Hardeep Singh, Professor of Medicine at the Center for Innovations in Quality, Effectiveness and Safety, IQuESt, at the Michael E. DeBakey VA Medical Center and Baylor College of Medicine in Houston, Texas. And Hardeep, you're obviously up early, and we appreciate you being with us here this morning. And I'm going to ask you to share your slides, and then we're going to hear you talk to us a little about diagnostic excellence, and then we'll come back and we're going to have a chat. Myself and Professor Eva Doherty, who's here with me today, we're going to have some discussion about what you're describing in diagnostic excellence. So Hardeep, good morning. Thank you.
Good morning, good afternoon, wherever you are. Thank you for inviting me. It's a pleasure being here and discussing this topic. So yes, this is a topic that I've studied for the last 2 decades or so, and would love to talk to you about it. This is what I'm going to talk to you about today. I'm going to start by telling you how we sort of defined the problem. I'm going to summarize 2 decades of our work in figuring out how we try to measure the problem, understand why these errors happen, and then talk mostly about what are the actions or strategies that can reduce the errors. So that's sort of like the important part. And over the last 5 years, that's where we've been focusing more so because we've sort of understood the basic science of diagnostic errors and diagnostic excellence. So I'm going to start out by a case. This is a 12-year-old boy, Rory Staunton, who presented to a pediatrician with symptoms of what seemed to be gastroenteritis, was sent to the local emergency room because she thought that he was looking pretty sick, with fever and belly pain and felt like throwing up and what seemed to be gastroenteritis. Well, he was given fluids intravenous fluids in the emergency room, and he was sent home in a few hours. Next day, he got a lot worse. He was brought back to the same emergency room, and then he was admitted to the hospital, to the intensive care unit. And 3 days later, he died from streptococcal sepsis. Now, unfortunately, what happened was on the first day when he came into the emergency room, his blood pressure and his heart rate really did not get better after he received fluids. That was one thing. Second thing was he had mottling of the skin, which, as you can imagine, you can never get with gastroenteritis per se, but nobody did a physical exam. So it was there. In fact, the pediatrician had documented it, but it was not picked up by the emergency room. And the third thing was he had a lab count which was abnormal. So his white cell count was about 15,000, which you might say, well, that's not very high. But his bands, which was suggestive of sepsis, was about 54%. That means he had a blood count which was very suggestive of sepsis. But the blood count came back a couple of hours after he was sent out the first day. So nobody looked at that blood count till the time that he came back the following night when he was admitted to the intensive care unit. So nobody really picked up on that white blood cell count and bands abnormality till the next day. And unfortunately, signs, symptoms, and lab findings of sepsis were missed, and Rory Staunton unfortunately died. And the reason you see this in New York Times is because the family tried to get hold of the medical records, and they were told by the hospital that they wouldn't release it. And so they got hold of a New York Times reporter who got hold of the medical records and broke the story. Now, how common are these types of problems? They're quite common. Some of the research we've done in the US shows that about 12 million adults might have a diagnostic error every year. Now, not all of these are harmful. Some of these are just sort of minor errors. But no matter what setting you look at, whether it's pediatrics, hospitalized patients, and there's data from UK as well that we worked on, which shows about in primary care consultations, about 3 to 4% of consultations may end up having a diagnostic error. So this is quite a common problem. Now, let's talk about definition. What are these things? Let's sort of form some sort of a shared mental model to understand what these are. This is a compilation of various definitions that the Agency for Healthcare Research and Quality came up with in the US, where they said that diagnostic errors can happen when one or both of these criteria are met. The first one is quite traditional, right? Which is what we think about as diagnostic errors, is delayed, wrong, or misdiagnosis, when there are certain types of missed opportunities that might happen that lead to these delayed, missed, or wrong diagnoses. But then they also say that sometimes when you don't communicate the diagnosis to the patient, even though it might be correct, you made the diagnosis, but you never communicated it to the patient, that could also be a diagnostic error. Just imagine that there was a pathologist who made the diagnosis, there was a radiology report which had a diagnosis of cancer, for instance, but then never got communicated to the patient for, let's say, 6 months to a year. That would be considered a diagnostic error as well. So the diagnostic process, this is the bottom picture is an adaptation from a landmark report, Improving Diagnosis in Healthcare, which was released by the National Academy of Medicine, which is some of the same people who are the Institute of Medicine who released the report on Tour is Human. They came up with a 2015 report on diagnosis, and the bottom picture gives you a little bit of an idea of what the diagnostic process looks like. Now, imagine in the real world, it is not as linear as it looks in this diagram. But essentially what happens in the diagnostic process, patient seeks help, help care for usually a symptom or a problem. There's history, physical exam, there's consultations, there's testing. All of these things happen. There's information gathering, there's information interpretation, and then somebody comes up with a working diagnosis, which then gets refined as additional data unfolds. Usually there's a lot of uncertainty, and there's a lot of evolution of diagnosis that happens over time. And then the diagnosis gets communicated to the patient, and then there's treatment. So this is sort of what the diagnostic process looks like. Now, in the real world, the diagnosis is not just something that happens in the mind of a clinician. As you can see, the human brain up there, decisions are not all in the human brain. The diagnostic process is also impacted by technology and the systems that we have around us. So this is why you see those arrows, that it's the clinical reasoning, the decision making, but then also compounded by the work system, technology, and such that impacts the diagnostic process. So what are the types of diagnostic errors that happen in malpractice claims, at least? These types of things, as you can see, common conditions are often missed, delayed. So it's cancers, and again, common types of cancers, cardiovascular conditions, infections. We talked about Rory Staunton's sepsis story. But we've got to realize no specialty is immune. We've described diagnostic errors in surgery. We've described diagnostic errors in pathology and radiology, even those visual specialties where things can actually be a lot clearer than the clinical side, we can still have diagnostic errors. Now, the other thing, other than the fact that these things are fairly impacting not just the what we call the diagnostic dilemmas or the zebras in medicine, but these things affect common medical problems, common diseases, heart failures and cancer. All of these things are, we see them quite commonly, not just rare conditions. So another theme that comes up from our research studies is a lot of these missed opportunities that we see, we call them missed opportunities in diagnosis. A lot of these missed opportunities are related to some history of physical exam or testing issue. So it's either eliciting or acting upon some key clinical findings. A lot of history and exam stuff, basic clinical skills is why we are seeing some of these issues. And now with the advent of electronic health records, sometimes the data gets buried in the electronic health record, so we can overlook information in the medical record as well, and that's how sometimes we get these diagnostic errors. There's many contributing factors, which is, data gathering issues, knowledge issues, testing issues, communication, biases and heuristics are a huge one. So there's lots of issues why you could have a diagnostic error. So over the last decade or so, we have tried to sort of think more about not just diagnostic errors, but how do we reach what we call diagnostic excellence? And to make some concepts measurable, you have to sort of define them. So this slide gives you an idea of how we define diagnostic excellence in our work. So we were talking mostly so far about diagnostic excellence being making a correct and timely diagnosis. That's sort of generally, we think that's what it entails. But it also means we need to make sure that we make the correct and timely diagnosis using the fewest resources. Now, it doesn't make sense if I order a CAT scan on every single patient who walks in through my emergency room with abdominal pain. Now, that's not good use of resources. I might find, 1 out of 200 CAT scans is abnormal, but that's not good use of resources if I do a CAT scan in every single person who walks in through my emergency room, because that's bad use of resources. So diagnostic excellence involves making a correct diagnosis using the fewest resources. The other attributes are you have to maximize patient experience. I talked about uncertainty before. We have to be able to manage and communicate uncertainty to patients. They need to know that sometimes diagnosis evolves over time. It involves uncertainty, and things can change. And then sometimes we have to tolerate watchful waiting because unfocused treatment may actually be more harmful to the patient. So all of these attributes of diagnostic excellence are important to keep in mind as we sort of study them and get to know more about this topic. The other concept we've been exploring a lot in our work is to achieve diagnostic excellence, we need better calibration. What's calibration? Calibration is the alignment between how accurate I am and how confident I am. So if I make a diagnosis of diabetic ketoacidosis, and if I'm 95% confident and that's what the diagnosis is, I'm well calibrated. So what we decided to do was to do an experiment to sort of test out this process of calibration for physicians. Our hypothesis was in experimental cases, in the middle of difficult diagnostic dilemmas or diagnostic cases, the physicians would be a lot less certain and they would be more likely to ask for help. So that was a hypothesis. And in fact, what should happen was their confidence levels would drop as opposed to easier cases. So we gave them 2 relatively easy cases, and we gave them 2 very, very hard cases in vignettes in an experimental study. Obviously, they did not know which were easy cases, which were hard cases. So they basically just try to solve them over the computer. They had as much time as they wanted to take, no rush. And we let the cases unfold like the way they unfold in clinical practice. First, you have some little bit of history, then you have some exam findings. And every step of the way, we ask them, tell us your differential diagnosis or what you think this patient has, and give us your confidence level in that differential diagnosis. So right before the end, as the vignette was getting over, we also asked them when they had a lot of diagnostic data, would you like to seek help? Would you like to seek help from a computer or a human in terms of, a colleague, a curbside, or a consultation? Would you like to read a book? Would you like to sort of order another sophisticated test? So we asked them these resource questions right before we, sort of finished the case. And towards the end, we asked them, tell us one diagnosis and tell us the confidence that you have in that diagnosis. And here's what we found. I want you to look at only the left side, which is the easier cases. The dark dots are the confidence levels, and the hollow dots is the accuracy. So at the end, their accuracy was about 56% for the easy cases. That means 56% of the physicians got the easier cases correct. Their confidence was about 0.7. This is a Likert scale, so it's sort of like scaled down. Now let's go to the harder cases on the right. If you look at the accuracy, it's about 6% average. So 6% of physicians got the more difficult cases correct. But look at their confidence, which is the dark dots. The confidence is almost identical as the easy cases. That means even in the middle of very difficult cases, physicians were fairly confident about their diagnosis. That means their uncertainty level did not drop. And they did not ask for help. Not a surprise. So what does this show? This shows that physicians' diagnostic accuracy and confidence are not aligned. And we call this concept miscalibration. And the reason it's more important today than ever before is because everybody wants to surround clinicians with technology, with apps, artificial intelligence, and we think that physicians will sort of use it and everything will get better. But if physicians don't seek help in the middle of very difficult cases, we're not going to be able to sort of make progress. And one of the biggest implications from the study was feedback is essential because the way psychology works, the psychologists have taught us that calibration can get better with feedback on your own performance. That means when you know how you're performing, you learn and you get better and you get better calibrated. So we wrote a paper, and I'm going to quickly walk you through some of these strategies for your own practice. This is a paper we wrote for BMJ, where we came up with 5 strategies that would be useful for clinicians to achieve diagnostic excellence. And of course, we started off with feedback. There's many ways to do that. One is you learn from your own cases on your own, or you have somebody else give you feedback, whether it's your colleague or your boss or your patients. So there's many ways we can do feedback. The let me actually just walk you through these things. So with the first strategy is about feedback, and you understand now why this is so important. It's important because it gets you a better understanding of how you're performing yourself, and this is where the calibration part is important. And how do you do this? So you can create a list of patients when you go to the hospital or your clinic. You just keep a list of patients, then you go back to see, hey, what happened to that patient? You can ask colleagues or patients about your performance as well. There's a new resource that we've developed with AHRQ's sponsorship. AHRQ is Agency for Healthcare Research and Quality in the US. It's an agency that does a lot of work on quality and safety. And it's called Calibrate DX. And this is the way you can actually get feedback on your own performance, either with yourself or with a colleague. Let's say there's a trusted colleague that you want to sort of work with. The two of you go through cases and give each other feedback on those cases. So it's essentially a resource that walks you through how to do feedback at an individual level, maybe working with a peer, a trusted peer, or maybe a superior on your own cases and learning from them. It's a self-reflection exercise. So I would encourage you to look at this resource. Now let's go to the next strategy that we proposed. The second out of the five strategies was what we call bite-sized practice. We basically said this because we wanted everybody to do small chunks of reading and doing cases, and bite because a lot of these are digital cases. We know that test-enhanced learning promotes knowledge acquisition. So we want to try to get everybody, all physicians should be doing, maybe several times a week, just like you go for exercise a few times a week, do it as a routine. Because it really helps you. These cases, a lot of them are available online. And we gave examples of where you get these brief diagnostic challenges from, which is why we call it BITE, B-Y-T-E, from social media, electronic journals, apps. Here's some resources for these short digital cases that people could use, 5 to 10 minutes a day, multiple times a week. And you can do these cases and keep improving your knowledge. Now, what about biases? So this is both implicit and explicit, biases. You need to learn about your biases because it promotes humility. It's really important to recognize some of the impact of harmful societal forces. And there's a bunch of things you can do at the practice level. For instance, you can look at your own patterns or in diagnostic evaluation. If you're doing drug tests on only a single set of, population, you might be sort of missing others as well. So then the next strategy is about making diagnosis a team sport, which is basically means diagnosis is not just something that happens in a single clinician's brain, but think about, other people around you, the nurses, physical therapists, speech therapists. That we've seen now more and more cases where other people who are in the healthcare profession also support diagnosis. There's specialists, pathologists, radiologists. So making diagnosis a team sport is really, really important because that's, it's not just the purview of the doctors by themselves. So how do we do that? We got to flatten the hierarchy. We need to have better group decision making, inviting patients, and then ultimately technology is a part of the team too. And so, this is where a lot of the conversation in artificial intelligence comes in as well. And then the fifth strategy we explored was critical thinking. And I know critical thinking is not routinely taught in medical school, but it does optimize data acquisition and interpretation. And the question is how do you take a skeptical stand towards your own provisional diagnosis? So let's say a patient with headache who's not getting better, new onset headache, it may not just be the migraine that you diagnose the patient with. It could be something else. So you got to make sure you seek those prompts for further investigation if the patient doesn't improve. And that's, critical thinking is really part of the diagnostic process. So what else can clinicians do? There is more and more data that supports that physicians generally do not do incident reporting very well. A lot of the incident reporting data is coming from nurses and some from pharmacists, but physicians don't do this very well. So there's been now several endeavors where physicians have been sort of engaged through multiple mechanisms to report more diagnostic errors, because they know about these diagnostic errors. They know their own diagnostic errors, and they know their colleagues' diagnostic errors as well. So there was a very nice study in Cincinnati Children's Hospital in the US where a fellow essentially had a project in which she created a safe space and called them sort of learning opportunities, not diagnostic errors. Did some focus groups and came up with a definition of what's a diagnostic learning opportunity. Essentially, when something useful in learning, there were useful lessons from your experience in a case that would be useful for somebody else. And went around physician call rooms and encouraged people to report. She built an alternate system, which was not in the routine incident monitoring systems of the hospital, with just a simple reporting process, name of the patient, medical record number, and just a quick 2 lines of what was the learning involved. And sure enough, in 6 months, she had almost 100 cases of diagnostic errors that physicians had reported to her. Because she created the safe space, there was leadership engagement, there was support for this project. She was the champion to collect the cases and analyze the cases. So it's a sort of, it can be done, but you do need some frontline physician engagement, leadership support, and perhaps an alternative system to report to make it easy for physicians to report these things and not have to fill up a huge form, incident reporting form, which sometimes can be a problem. So now we talked about diagnostic excellence on the individual level, but I think the goal is to also improve the system around us. So we've also started thinking more about how does a healthcare system or a healthcare organization achieve diagnostic excellence. So we've come up with this term called learning and exploration of diagnostic excellence, also called the LEAD model, where we say that organizations also need to have 5 traits to try to become go on their journey for diagnostic excellence. And one is you need to be able to sort of measure some of these diagnostic processes for improvement in learning. Just like in patient safety, we do a lot of measurement. We also need to measure the diagnostic process, measure diagnostic errors through multiple mechanisms. We need to be able to translate new evidence into practice. So over the last few years, we've tried to develop a lot of tools, help people on the front lines, whether you're clinicians or whether you're healthcare organization leaders and quality and safety professionals, to use these tools. Essentially, what we've done is we've translated research into practical tools and guides and checklists for people to use on the front line. So that's the second box you see on the top. We need to engage clinicians. I gave examples of that. We need to learn from patients. Patients give us a different story when you learn about why they have diagnostic errors, and we can talk about that in our Q&A as well. And then most important is we got to have some sort of organizational body to try to coordinate these activities, whether it's virtual or in person, but there should be some kind of a group at the health system level that is coordinating activities around diagnostic excellence. So you need all of these 5 to make progress in diagnostic excellence at the organizational level. And I know that there's a lot of talk about AI these days, and because diagnosis is a prime sort of target for AI, almost every meeting I go to now, there's talk about using AI. There's an implementation gap that AI can sort of help fill. And so we wrote a paper recently that might be of interest in how health IT and AI could be improved, be used to improve patient safety and diagnosis. And so I think one of the things in top of everybody's mind is, could large language models and AI help, generative artificial intelligence help? And the answer should be, if developed and tested correctly, it might help clinicians make a diagnosis, but also it needs to get into the clinical workflow, because a lot of the studies that are happening right now, all they do is they give a very well-structured case with all the data to artificial intelligence, and artificial intelligence makes the diagnosis, and everybody's like, yay, like AI wins. And it's not about AI versus doctors in this case. I think the question is, can the physicians use AI to improve their diagnosis when they most need it. And think back to the confidence study that I just sort of described. You have to be able to know that you need to use AI. There was a story, I think it may have been from UK, I can't remember, where mother went to 17 different doctors and didn't get a diagnosis, and she put the entire story in a large language model, and the diagnosis was tethered cord syndrome, and got the diagnosis. Now, I'm pretty sure that one of those doctors could have put the same story in the chat GPT or LLM and got the same diagnosis. But the point is, when the data is all available and structured, if somebody knows something doesn't make sense, let me seek help from another, something that might be as smart as me, and then help get the diagnosis. So that's sort of, just think about, 17 different doctors didn't use technology or AI to help, but the mother decided to do it herself. The other thing about why AI is being hyped a lot these days is also potential efficiency gains. We've seen more and more sort of studies coming out where AI could be used to support documentation or responding to patient messages and such. That can actually free up some time for clinicians' decision making, which, as most clinicians imagine, they don't have enough time. So if you free up time because AI is doing some administrative tasks for you, that's great. And lastly, we talked about differential diagnosis, which has been a problem in some of our studies. We don't do enough differential diagnosis. Again, if we enhance our differential diagnosis by using AI, that would be a good thing. So I want to end here and open up for questions. And again, thank you so much for having me. I think we have plenty of time for discussion. Thank you.
Thank you, Hardeep. That was really fantastic, and as you know, we're really just scratching the surface here, but we've already covered so much there, and it's been a pleasure to hear you speak. I'm joined by Professor Eva Doherty, who many people on the podcast or the webinar will be familiar with. Eva's a professor at RCSI and director of human factors and patient safety programs there. Eva, I know you're familiar with Hardeep's work as well, and it's great to hear him. It really is, lifting the cover, isn't it, on diagnosis and having a look inside maybe the black box. I got into this a little bit over the last few months, reading a book, I think, Hardeep, that you edited called Diagnosis, Interpreting the Shadows. And I think it really is, it's a difficult area to research and to find out about and to get people probably to talk about and to understand. And I know when I've made a diagnostic error, it's something I'm not proud of, and maybe I don't want to talk about it. How do we get people talking about this and being more open?
Yeah, I think a lot of physicians are very sensitive about the topic, as I think the best I can put it. There's a lot of pride in people's competence and skills around diagnostic decision making. I still remember when I was in medical school in India, a lot of our professors would pride themselves in being sort of the best diagnosticians. And I think we're taught that is our core competency. We have to be able to diagnose correctly. And it's not easy for us to sort of accept the fact that sometimes we miss a diagnosis. And I think over time, which is why we sort of changed the language, we started off with diagnostic errors. We realized that that word wasn't resonating very well. Yeah. We then went into missed opportunities. So, how can you sort of learn from your missed opportunity? And then lastly, then the term was learning opportunities as a Cincinnati study. And now we're talking mostly about diagnostic excellence. Like, forget the fact that, we all make errors, but how do you achieve diagnostic excellence? So we've gone from error to excellence in about 20 years to try to make sure that physicians can sort of accept this topic more easily and start to have open conversations.
Yeah, thanks. Eva, how does that resonate with you in terms of, as a psychologist and as someone who teaches human factors in healthcare?
Oh, I just loved Hardeep's presentation so much, and I think Like, we're so privileged to just get all those fantastic nuggets that he's given us there. And I'm thinking, the language that we use is so crucial, and totally agree. And because the language that we use governs our thinking patterns, governs our attitudes at the end of the day. And so we do have to turn it on its head and become much more open and transparent about all this in order to learn. I think, like, in Ireland, we've so far to go here. But, I'd love at some point, if we could have, for example, a national repository stroke website where people could upload the stories of, their times when, maybe it was a bit of a journey to get the right diagnosis, and what happened along the way and all of that, just to promote learning. There is precedence for this, quite close to home, actually. The surgeons in the UK have gotten together, and they have a website which is called CORES, or CORES, CORES.org.uk, and that is where people voluntarily upload their stories of not about diagnoses so much, but about near misses, which I prefer to call good catches, what they call precursor events, as a way of promoting learning. And, like, I'm hoping this is where we're going in healthcare. I think, by definition, people who go into healthcare, they tend to be very conscientious, very perfectionistic. They don't do mistakes, in inverted commas, well. And then we don't support them either. I heard a story lately of somebody who was reporting needle stick injuries and got into trouble, because the attitude was, what's going wrong in your team? You're reporting too many. And you kind of think, sorry, we're not going to get anywhere with that attitude. We really have to turn it on its head.
And one of the things I think, that helps this is this idea of creating a safe space. I think Hardeep talked about it in several of the examples he gave, where clinicians, were coming to share those things. And this concept, I think, of psychological safety, which we're realizing underpins a lot of what's needed for us to make care safer. And is that something you'd see in your work in human factors as well?
Oh, big time. We talk about that a lot. And I think the way the literature has gone now is that, the evidence about it is pretty well at saturation level. We know it's crucial. I think what we're researchers, and I was reading a review paper written by Amy Edmondson just lately, what she's calling for now is, how do we actually make it happen? And the way we make it happen is in our conversations. And it is our conversations that are key. And I'm going to say it's our conversations with patients and with our team members that facilitates what Hardeep is advocating for. It's all down to the conversations and the skills that we use. And there's an assumption that, we have those skills instinctively, and some of us do, but lots of people don't have those skills, and they need to learn them. And they can be learned. There's loads of evidence to show now they can be learned. It's not either in you or not in you. It can be learned, and it makes massive difference to what Hardeep is advocating here for in terms of diagnostic excellence. It's like the old-fashioned art of medicine. Let's go back there before we had all this technology.
Yeah, it's very much blending that the art and the science. And I think, many of the areas we're talking about are scientific, and I notice, Hardeep, there's a question there, which is really, I suppose, from Anne Jones, which is really focusing on maybe biases. And do you think that once a working diagnosis is reached and documented, that other clinicians become blinkered to the implications of new information results as it becomes available? Does the momentum to continue on the direction first set lead people to disregard contraindications and the new test results and clinical examinations? There's probably half a dozen biases been described in there, and how do we tackle our biases? And I know you gave us some guidance with some of the tips you had there, but anything to add to that?
Yeah, well, I think we have to this is where the learning from your own performance is useful. a lot of times we don't find out about these things because nobody told us. So oftentimes I'm learning about that case that I transferred to another physician, like very incidentally. 3 months later, some physician stops me in the hallway and says, "Hey, do you remember that case that you transferred to me a few months ago who had this, this, and this?" I'm like, oh, maybe, yeah. And then they say, "Oh, by the way, this person didn't have this condition, but they had this other condition," and so on and so forth. All of this is quite non-routine in medicine, learning from our own performance of our own cases, and we need to sort of routinize it. So we've been trying to advocate for building better feedback loops to physicians so they know what happened to their cases. And that's where sort of that tool, Calibrate DX, I was discussing, could be useful, because you can literally look at your own performance over time and look at routinely. So we say every 3 months, you should spend 3 to 4 hours looking at least 5 of your cases, ideally with a trusted colleague, or just do it yourself. Which cases, and we help you select that when you use a tool, which cases would you like to look at? That's depends on where you want to focus. But I would say that all our research shows that's probably one of the best strategies to overcome some of your
and even just becoming familiar with these biases is to know that they exist. Eva, you and I had spoken about this before, and things like anchoring bias or confirmation bias. Those are helpful things to even have a language on, and then we can share them with our teams, and maybe even look out for each other when we're falling into these kind of traps that are really are to be expected.
Yeah, absolutely. And actually a tactic that we teach, and wondering, Hardeep, what you think about this too, is which our surgeons quite like, which is the idea of a pre-mortem versus a post-mortem. Apparently it comes from the military. So it's like thinking through, what if our plan of action or treatment or diagnosis, whatever, turns out to be wrong? Why might that be? And sort of almost backtrack. And that's something you could do as a team. If we're wrong here, why might that be? And it's just kind of, as you say, it's taking account of your biases and our faulty decision making. But even I think just accepting as human beings that we don't get these things right is step number one.
Well, there's a cool concept, and you must be familiar with it, called requisite imagination. Basically, requisite imagination is you figure out, if you're developing or designing something or doing something, what could be the potential failure points. And it helps you think through things that can go wrong proactively. Certainly in medicine, we don't do a lot of proactive things. We do a lot of reactive thinking and a reactive reaction to fix this, let's fix that. But proactively, we're not very good at doing things in healthcare. So I think your point about doing things more proactively is a really good one. And it also brings around the concept of what we call sort of safety 2 now, which is sort of, learning from what's going right versus always reacting to accidents and bad events, which is safety 1. So another safety 2 concept perhaps to explore.
Yeah, and I think this is what I like about this. Your idea of diagnostic excellence is that it allows us to bring in a lot of these, really understanding, where does real diagnosis happen? What are the critical steps, and can we just do those better? And obviously, when it goes wrong, that's a way of showing us kind of that there's a problem. But there are lots of things that we can be doing to make sure it goes as right as possible. One of the other things I like in this, and we touched on it in our podcast, which I'll direct people to afterwards, is the idea again of sustainability here, I think. And I was at a talk recently, a seminar at the weekend on sustainability, and one of the big focuses, I think, in sustainability in healthcare is about trying to reduce low value care. And I think diagnostic excellence has a really big role to play here, because it kind of starts the ball rolling, and if we get the diagnosis wrong, or the diagnostic process wrong, over-diagnosing, over-investigating, then we're setting ourselves up for doing lots of things that are going to be a poor use of resources, including the generation of emissions and wasting of money and resources that could be used better elsewhere.
Yeah. No, thanks for pointing that out. This has been, over the last few years, has become a topic that I'm increasingly getting passionate about. And I didn't actually realize there was a sort of overlap of diagnostic excellence in the context of climate change. And we just recently wrote a paper on that. And it's exactly the way you describe it. A lot of these emissions are coming from what we do in healthcare, such as prescribing, testing, doing procedures. And we know, because the data shows about 30% of healthcare is low value or wasteful. And imagine if we were to get rid of all those things, we would save 30% of the emissions. As physicians, we control a lot of that testing, a lot of those procedures, a lot of those a lot of that care that's unnecessary. We could definitely improve environmental sustainability if we have better diagnostic excellence as well.
Great. Yeah. One of the things, again, I was struck at the beginning of your talk, Rory Staunton is buried here in Ireland. His parents are Irish, and they have been great contributors to discussions around sepsis in Ireland. And I suppose one of the big questions, and I know our audience is always interested in this, is how do we get patients more involved in the diagnostic process? And I think maybe for both yourself and Eva, the thoughts on, it's opening up diagnosis to be, and I think you talked about it's a team sport that includes patients and families and includes their perspectives and the perhaps they're often the people who can are only able to see certain things and helping to bring forth their perspectives and ideas as well into diagnosis. Eva, any thoughts on that maybe?
The HSE here in Ireland is doing a lot there for that in terms of empowering patients and families to, ask the questions, raise the concerns. I know, John, you've been involved with the early warning score in terms of, listening to families' concerns. And, this is the way we're going. And it's so it's crucial, if you think about it, to be involving patients in their own care and listening to them. But again, it's like a dimension that isn't probably, it's being emphasized now a lot in undergrad healthcare professions education, and that's to be welcomed. But it's relatively recent, that patient participation and representation is something now that is fully supported. So I think on the ground, there's a bit to go yet.
Yeah, no, I agree. I think there's patients are one constant through the diagnostic process, as we as a healthcare system and as clinicians are so fragmented, but patients move between emergency room, primary care, hospital, lab, radiology, referral, different physician. They know the longitudinal diagnostic process much better than we do, right? Because we often don't have the data that is coming from other places. And learning from the experiences has been really critical. So when we talk to patients as to what was the reason why they misdiagnosed, one of the most common reasons we find that they tell us is the doctor didn't listen to me. And so that you don't get from a medical record. We don't get that from an incident report. You get that from learning from patients. So we've tried to get a lot of data from patients on diagnostic safety, diagnostic error. There's lots of organizations trying to engage patients in sort of what's called PFAC, Patient and Family Advisory Councils, where they are a part of a team that advises the healthcare system of clinicians and how you improve patient safety. It's not necessarily for patient safety, but it could be emphasized for patient safety. There's patients who are trying to do advocacy and policy because of some of their experiences. And so I think patients can have a huge role in this field because it is such a central process to them, versus just getting a medication or a treatment.
And I think also the things that happen during the diagnostic process, the trust that's built, the relationships that are built. And I think, you spoke about AI earlier, and I think, the risk that people perhaps bypass healthcare and go straight to Dr. Google or Dr. GPT, and look for answers. I think, the the healthcare professional is still very important there, and obviously in partnership with patients, and maybe even enhanced by AI. So it's about bringing all the pieces together, isn't it?
Yeah. And there's a great line in that old movie now called Patch Adams with Robin Williams in it. And he says, you know, if we focus on the disease, we can win or lose. But if we focus on the patient, we can never lose. And, you know, and so, you know, if you've got the patient as in the center, then you're never going to lose. And that has to appeal to the perfectionists amongst us, I think.
That's really super. Thanks. I'm just looking at another comment there, just from Tom Crotty, just in diagnostic pathology, the National Quality Assurance Guidelines require us to obtain a second opinion in a minimum percentage of cases. And also many of our diagnoses are reviewed by colleagues at multidisciplinary meetings. This goes a long way to reducing error. So that's back to your point of it being a team sport, isn't it, Hardeep? And I think and no shame in that, you know, and we need other people to help us calibrate.
Exactly.
Well, folks, I'm gonna leave it there. Thank you very much, Hardeep. I know it's early in the morning in Texas, and we do appreciate you being with us. And Eva, thank you so much as well for joining us today. I'm just going to close out with a couple of slides, and I'd like to thank our speakers and wish them well. Thank you.
Thanks for having me.
Pleasure. So just to flag up there, that today's webinar will be is recorded and will be posted. But we also, and I just recently listened back to it. We did a lovely podcast with Hardeep back in the autumn. Myself and Eva had a conversation, and we touched on many of the topics today. And that's available to listen as part of a special series of podcasts that we did for World Patient Safety Day, where the theme was really around diagnostic excellence this year, reducing diagnostic error. So I'd certainly encourage people to check those out and check out the other podcasts in that series. Please join us in 2 weeks' time for what proves to be another very exciting QPS TalkTime, where we are going to be launching the Quality and Patient Safety Competency Navigator. And this is something that we've been working on for a number of years. It's been a really great piece of co-produced work where people across the healthcare system, including lots of patient input, we've identified the critical competencies for delivering quality and patient safety within healthcare, and we're looking forward to launching that and making people aware of all the great resources that will be within that. So there's a QR code there just to join that session in 2 weeks' time. Please do share your feedback. You'll get a form as you close out from the webinar today, or you can use the QR code here. And again, if you have any thoughts or ideas for future webinars, please let us know. And again, like I said earlier, we're on YouTube, and you can watch back all the previous episodes. And we really have several excellent conversations now available for watching. And I think that's it from me. Please do join us in 2 weeks' time. I do want to thank again Bonita, who pull everything together. Thanks again to Eva and Hardeep, who joined us today. And I want to give a special shout out to Shima, who did the podcast series with us. Really fantastic job. And I really would encourage people to check those out. And I look forward to seeing everybody in 2 weeks' time.